Hello. This is video 2 of your 3-part PCOS series. So if you missed the first video, we went over some signs and symptoms and the diagnostic criteria of PCOS. So you can after this video, you can head on out and catch that one as well. But today we're actually going to talk about how do you know, meaning you think you do because you watched the video and you've done some research and you have a lot of the signs and symptoms, but now we need to do some testing and we actually need to get you a proper diagnosis. So what do you gotta do? We're going to talk a little bit about the blood work. We're going to talk about why I don't push women to get an ultrasound. And then in part 3 of this series, we'll actually go over some of the techniques that I use in practice and some of the treatments that I do and some of the research when it comes to PCOS. So oftentimes in Guelph, I have women come into my office and they've either been diagnosed with PCOS and they need help, or they don't really know what's going on and they have all these signs and they thought they might have PCOS. They went to their doctor did an ultrasound, and these women say to me, well, my doctor sent me for an ultrasound. I don't have cysts, so they told me I don't have PCOS. And again, my only option was birth control. This is a huge myth. You do not need to have cysts on your ovaries to have PCOS. And so if you watched the first video, you know I went into this already. This is the biggest thing for me. They changed the diagnostic criteria so that you no longer have to have those cysts. And there are lots of women walking around with PCOS and no cysts. And there's lots of women walking around with cysts that don't have PCOS. So it was a huge change in the diagnostic criteria. So if an ultrasound really doesn't help you all that much, then what do you need to do? So I'm going to go through some of the blood work that I run with my patients and why. And these are things that you can either see if your doctor has run, or you can find a healthcare practitioner that will do this for you. So the first two are LH or luteinizing hormone and FSH, follicle stimulating hormone. Both of these are pituitary hormones, and they essentially start the whole hormonal cascade. So FSH actually helps us to build that healthy and mature egg, while LH helps to trigger ovulation of that egg that FSH matured. So if you're not having a period, or you're having really long cycles, then it's actually worth checking your LH and FSH on day 3 of your cycle. Day 2, 3, or 4. 3 is optimal, but no later than 4. And then in women with PCOS, you might actually find that your LH is 3 to 5 times higher than that FSH, when they really should be about equal, give or take a little bit on day 3. If your LH is chronically high, you likely aren't ovulating, because we need that LH surge in the middle of our cycle to actually release the egg. So if you're already sitting quite high, your body can't stimulate that surge effect, that going from low to going to high, that's going to trigger the release of the egg. So this is something that we need to check in on. Again, like everything, not all women with PCOS have that LH-FSH ratio imbalance. Not all women with PCOS have chronically high LH. So it does help us to make sure we're managing your case the best way possible, but this doesn't necessarily rule in or rule out PCOS. The second one is progesterone. So if someone isn't having a regular period, or if you're having really long cycles, we actually want to see where your progesterone is about 7 days after ovulation. This is when progesterone should be at its peak. We do not make a whole lot of progesterone in the first half of our cycle. Once we get that LH surge, the egg is released from, I call it the shell, and that shell forms something called the corpus luteum. It's actually this that makes progesterone in our bodies. So you can see if we are someone who isn't ovulating, we're not releasing an egg, we're not giving off that corpus luteum, we're not making progesterone. You can have really long, horrible cycles this way, obviously. And we can have a big progesterone estrogen imbalance if we're not making that corpus luteum. The same thing can happen if you're releasing an egg and the corpus luteum is like so, and you're just not making enough progesterone, your body's not making enough progesterone, then this test will also help us to decide, yeah, you ovulated, but your body's not doing an awesome job, let's support it. Or no, you didn't ovulate, or yeah, you ovulate and you actually make pretty decent progesterone, so that's a good thing. Just to clarify this, 7 days after ovulation. So this is something you'll need to do cycle tracking for. We need to know exactly when you're ovulating, give or take a day or two, and then you'll go into the lab about a week later to actually get your peak. So if you are someone who has a 38-day cycle and you're being sent for progesterone on day 21, you are not getting an accurate reading. You likely haven't ovulated until actually a little bit later than that. So you're going to be getting a really, really low progesterone when in fact it's only because we missed your ovulation. So if you read online, a lot of places, blogs, opinions, things like that say you need to test your progesterone on day 21 of your cycle. This only works for women if they have a 28-day cycle, if they have a textbook cycle. Most women don't have a textbook cycle. I think it's like less than 5% of women have a 28-day cycle. So you need to figure out what is your day 21, which is 7 days after ovulation. If you ovulate on day 14, then yes, you will go on day 21 for your testing. But if you ovulate on day 20, you will go on day 27, and then we'll expect you to be having your period on day 34. If that math is correct. So you got to make it work for you. You cannot go by what the blogs are telling you. The next one, we're getting into some metabolic testing, which we chatted very minimally about in the first video, but fasting insulin and fasting glucose. So here we're looking for insulin resistance, which is really common with PCOS, but again, it's not necessary. I have some women in my practice with androgenic PCOS. It's not coming from an insulin problem, but I do find this is very, very common with women who have PCOS. What essentially happens is your body's no longer responding to insulin the way that it should. So your insulin and your glucose are kind of floating around freely in their body. This can lead to weight gain or the inability to lose weight, but it also really impacts ovulation. So when there's insulin floating around because your body doesn't know how to manage it or what to do with it, it creates this inhospitable environment around your ovary. So it actually tells your ovary to make testosterone. So oftentimes if your testosterone is high, we really want to make sure that your insulin is actually in check, because if that's where the high testosterone is coming from, treating your testosterone and trying to lower it really isn't managing the root cause. We actually need to manage the insulin resistance. So both of these tests, insulin and glucose, fasted, meaning about 12 hours overnight. So you're going to do them first thing in the morning, and then we actually run them in the HOMA-IR calculator and figure out if you are insulin resistant, whereabouts on the scale are you, and that helps us determine how we're going to treat. The last few tests are for checking your androgen status. So this is your free testosterone, your total testosterone, and your DHEA-S, which is an adrenal metabolite. All of these, if they're elevated, that's what's causing the unwanted hair growth on the chin, mustache, chest, acne, especially cystic acne, male pattern baldness. So we talked about in the last video that high testosterone can cause you to grow hair in places that you do not want it and cause you to lose hair in places that you do. So it's one of those really tricky ones. And if it's increased in the ovaries or in and around the ovaries, making that sort of inhospitable environment that we had talked about with the insulin, then it can actually cause that egg to get sort of stuck, not be released from the ovary properly. And it might be actually causing your cysts or why you're not ovulating, because that egg tries, your body, you have the LH, your follicular phase, your first phase hormones are doing great. They're doing what they should be, but the egg is released and that testosterone makes it kind of icky, so it can't really get out, it gets stuck, and a cyst forms. So this might be not the fact that you're not ovulating, but that luteal phase you're having issues because of your hormonal imbalance. So it's good for us to see where your testosterone is sitting, and it's also nice to just keep a baseline so that we know maybe your testosterone isn't high now and we're dealing with your insulin resistance, but we don't want it to go up. We want to make sure we're pushing it in the right direction. All of these tests are done in the blood. I also often recommend running a saliva cortisol, 4-point cortisol panel. It can be really beneficial if fatigue is an issue, if stress is an issue, as cortisol and your hormones go hand in hand. So I like to have the full picture when we're starting with a case versus chasing the dragon for a while and not really knowing exactly what's going on. That is it for testing. So next week we'll be doing the third video that goes over some treatment tools for you. So if you are interested, make sure you check back next week. If this video was helpful for you, please comment, like and share. If you have friends or girlfriends who are dealing with PCOS or think they have PCOS but aren't getting any answers, I'd love to help. I will see you guys next week.